Good evening, everyone. This is Dr. Ayushmati, and this evening I would be talking about chronic pancreatitis with specific focus on the diagnosis, the investigations, and the management. Chronic pancreatitis is an anxiety we are facing not very commonly, but the, the cases are constantly increasing in the OPD of late, and it is honestly a very difficult disease to manage, and it causes a lot of frustration on the part of the physician and a definite burnout on the part of the patient and the patient's caregiver. So with this, I'm starting the presentation today. And if you have any questions, you can keep them for the end of the presentation. I shall try to answer them. Can we proceed to the next slide, please? Can we proceed to the next slide? Yeah. So what is chronic pancreatitis basically? It is defined as a fibroinflammatory syndrome of the pancreas in individuals who have a genetic predisposition, or it can be environmental, or they have other risk factors, for example, smoking, intake of alcohol, and they develop a persistent pathological response to the parenchymal injury or stress. The next part of the slide, please. So if you see, the annual incidence rates reported worldwide are roughly similar in all countries, and they range from 5 to 14 per 100,000 individuals, with a prevalence of approximately 30 to 50 per 100,000 individuals. So it's if you just see, the numbers may actually vary because we don't report much of chronic pancreatitis, probably because the diagnosis goes, the case itself goes undetected. So from the Indian point of view, the scenario may be different than what we are seeing in this particular slide. Can we progress to the next slide, please? Yes, proceed. The pathophysiology of chronic pancreatitis is fairly complex. Yes, definitely. And it includes the sinus cell injury, a sinus stress responses, a duct dysfunction, persistent or altered inflammation, and or neuroimmune crosstalk. But at the end of the day, none of the mechanisms are completely understood. Chronic pancreatitis is characterized by an ongoing inflammation of the pancreas, and it results in progressive loss of the endocrine and exocrine compartment owing to atrophy and or replacement with fibrotic tissue. So this is very important for us. Progressive loss of endocrine function, and the patient goes to develop diabetes. The diabetes associated with chronic pancreatitis is classified as type 3C diabetes. And of course, a loss of exocrine compartment, and the patient will come with a history of maldigestion. Functional consequences include recurrent or constant abdominal pain, diabetes mellitus as a result of endocrine insufficiency, and maldigestion as a result of exocrine insufficiency. To the next slide, please. Next slide. Now, what you see here is basically the process that is happening. If you see, there is a sentinel event. Sentinel event is always the first event, as we say. The primary event which is occurring in these patients. So it is basically the injury that is happening. So if you just go into the details of this, primarily what is happening is basically an activation of Can you just, the slide is becoming very unclear actually. I just adjust my screen once.
Hello?
Hello? Yeah, the slide is actually a bit...
One moment.
Okay. No, the previous slide. You go to the previous slide. The slide is not over.
This one, right? This one or previous? This slide or?
This slide actually.
One moment. Okay, now you can see.
Okay, yeah. So it is basically the pancreatic stellate cells which are activated, and they are basically in a quiescent state in the initial phase, and they are activated, and they are converted into an activated part, which is the myofibroblast. And ultimately, what happens is a ductal obstruction, and there is definitely a pancreatic ductal hypertension. There is a lot of oxidative stress, hypoxia, fibrosis. So whatever we see at the end, like the abnormal ductal system, pseudoaneurysm, pseudocysts, ductal stones, biliary obstruction, venous thrombosis, duodenal obstruction, they all come as a consequence of the basic pathology which is occurring in these patients. Now, can we progress to the next slide, please? Etiology of chronic pancreatitis. Etiology can be easily given as for the Tiger O system. There is for T stands for toxic metabolic, chronic pancreatitis caused by alcohol abuse, tobacco smoking, hypercalcemia, hyperlipidemia, CKD, medications or toxins. Now coming to the medication part, a lot of alternate medications are being used nowadays by the patients, and the history is very important because recently we encountered a patient and we could not find the exact cause. Still, the patient gave us a history of taking OTC medications for OTC herbal medications for her vitiligo. So definitely that is, and that was an important history. Then idiopathic, chronic pancreatitis that is not associated with any known gene mutation, such as early onset chronic pancreatitis, late onset chronic pancreatitis, and tropical chronic pancreatitis, and early onset form of classic chronic pancreatitis that is almost exclusively observed in tropical countries in the developing world, and that is characterized by aggressive force. Now, coming to gene mutation, chronic pancreatitis caused by Mendelian disease involving the pancreas complex genetics or modifying disease. For example, the PRES gene and CFTR and SPINK. Now, SPINK and PRES gene are very common. They are basically the ones which are, when you do a genetic study in these patients, you will see that PRES gene and this particular SPINK gene are the ones which are involved very commonly. Autoimmune steroid responsive chronic pancreatitis, which can be isolated or syndromic. For autoimmune disease, you have to go for the autoimmune profile. You can go for ANA, you can go for IgG4. These are the tests that we can do, but for autoimmune, you should have a high suspicion that this patient is actually, this patient can be a case of autoimmune pancreatitis. Now, coming to the next, recurrent and severe acute pancreatitis. Recurrent chronic pancreatitis that is associated with necrosis is severe necrotizing pancreatitis, vascular disease, and post-irradiation damage. Ultimately, the last one of the Tiger O system is obstructive chronic pancreatitis that is associated with pancreas divisum, a congenital anomaly of the pancreas, sphincter of OD disorders, duct obstruction, for example, a tumor, and post-traumatic pancreatic duct scars. Now, can we go to the next slide, please? Now, what we would be doing, basically, classic chronic pancreatitis can be subdivided into a typical chronic pancreatitis, which is dominated by fibrosis, and atypical chronic pancreatitis, which is dominated by atrophy. Now, the later one, the atypical chronic pancreatitis, is usually an age-related disorder. We don't put it in the typical chronic pancreatitis. Typical chronic pancreatitis or the classical chronic pancreatitis, and that we say the typical chronic pancreatitis usually, most commonly, it was attributed to the intake of alcohol. The pathology is completely different from the atypical chronic pancreatitis.
চালাবো কি করে?
And what happened ultimately was when we went ahead with the CT scan and the fecal elastase was literally not detected in the stool, and that's when we went for the PERT regime. I will be coming to all these in the later slide. To the next slide, please. Now, the diagnostic criteria for chronic pancreatitis. The diagnosis of chronic pancreatitis involves several criteria, primarily recurrent bouts of pain with or without more than threefold the upper limit of threefold rise in the upper limit of amylase or lipase levels, and one or more of the following criteria. There is a radiological evidence comprising strictures and dilatation in the side branches and or the main pancreatic duct and or intraductal and or the parenchymal pancreatic calcification by CCT and MRCP. Histological proof of chronic pancreatitis from biopsy samples undertaken by endoscopic ultrasound or from a surgically resected specimen. I think the third point is something which is rarely done, very, very rarely done. But with the advent of EUS, especially when we need to differentiate between chronic calcific pancreatitis with a cystic adenocarcinoma, we often go for an endoscopic ultrasound guided biopsy, but otherwise it is not very commonly done. The diagnosis is usually based on the history of recurrent bouts of pain along with radiological evidence. In case of chronic pancreatitis, the amylase lipase levels may not be raised. So that is very important. Like in acute pancreatitis, the diagnosis is based on the increase in amylase lipase. But in case of chronic pancreatitis, the level may or may not be raised owing to the destruction of the pancreatic parenchyma. Coming to the next slide, please. Now, suspicion of a chronic pancreatitis. So you have, primarily you have the clinical feature. The patient is coming to your OPD with a pancreatitis like pain in the epigastrium, which is radiating to the back. Patient is coming with a history of maldigestion, significant weight loss, glucose intolerance, age is a factor. If there is a family history, you do have to go for further evaluation. Early age of onset, CF organ involvement, syndromic features, and IBD or evidence of IgG4 disease. Clinical response to treatment. Now, as I had said, there was a risk factor that is TILARO, which I have mentioned before. All these have been mentioned over here. And genetic testing. Genetic testing is a very interesting panel. If you have ever seen the panel of genetic testing, you'll see that they will give you a huge panel of tests. Huge. So, but the most common outcomes that we see, the two common gene affected, the PRS1, the FES gene, and the STING gene mutation. But we do have other genetic mutations which occur. In fact, initially, cases which were termed as idiopathic have recently been, after the advent of a proper genetic testing panel, we have been able to classify them under the genetic code. And imaging and serum markers, I would be coming into them in the subsequent slides. What you see is SMRCP. SMRCP is also known as dynamic MRCP. It's a secretin enhancing MRCP. That's a very interesting test. I would be explaining it to them in the subsequent slides. Coming to the next slide, please. Now, causes of pain. As I have mentioned, that pain is the cardinal feature of chronic pancreatitis, right? I think only in about 10 to 20% of patients, they may not complain of pain, but 80% of patients will complain of pain. Now, pain can be classified into three categories in chronic pancreatitis: primary, secondary, and treatment-related pain. Primary pain, that's called genuine pain. Now, doesn't mean the others are not genuine, but primary pain is actually termed as a genuine pain. So there is duct obstruction and tissue hypertension, active inflammation, tissue ischemia, altered nociception owing to cholecystokinin, related changes in the pain threshold, local nerve damage, that is a neuropathic pain, peripheral and central sensitization of the nervous system, and increased sympathetic drive. Now, primary pain is very difficult to control. What we need to concentrate is basically control of the secondary pain and the treatment-related pain. That is something which is comparatively easier to control than the primary pain. Why are the secondary causes of pain? They are local complications including pseudocysts, inflammatory mass in the pancreas, small bowel strictures, and adenosine. Remote complications include obstruction of the bile duct and duodenum, peptic ulcer due to changes in the blood flow, bacterial overgrowth due to changes in motility, mesenteric ischemia after acute pancreatitis, small bowel strictures after acute pancreatitis, and diabetes mellitus type 3C related visceral neuropathy. Diabetes mellitus type 3C related visceral neuropathy is one of the comparatively easier treatable causes of pain. Treatment-related pain, surgical and or the endoscopic complication, adverse effects to medications, opioid-induced bowel dysfunction, and opioid-induced hyperalgesia. As you all know that opioid medications are very commonly taken for control of pain in chronic pancreatitis. Coming to the next slide, please. Okay, as I was mentioning about the causes of pain in chronic pancreatitis, so we finished this slide. We can progress to the next slide. Now, scoring system. There are several scoring systems which are existing to evaluate the severity of chronic pancreatitis. I think everybody of you must have heard about the Cambridge classification for severity grading, and it uses ERCP, and its adaptation for other types of imaging is still used for diagnosing and scoring chronic pancreatitis in adults. The other systems are the ABC system, which uses a classification that consists of 3 stages combining clinical criteria, local complication. The clinical criteria is basically pain, recurrent recurrence of pancreatitis, local complications, steatoria, and diabetes, with imaging, ductal or parenchymal changes. The Rosemont classification can diagnose chronic pancreatitis using only endoscopic ultrasound criteria. The number of parameters correlates with severity of the disease as confirmed by histopathology. The Manheim classification attempts to characterize patients according to the etiology, clinical stage, and severity. The severity of the inflammatory reaction is evaluated with clinical symptoms and therapeutic intervention. For example, whether the patient is responsive to steroids. This is in case of the autoimmune pancreatitis that I was talking about. The rather complex classification criteria involves a point system describing the severity of chronic pancreatitis, the COPS, that is the chronic pancreatitis prognosis score. It's also called COPS. It predicts the individual short term, that is 12 months prognosis using CRP, thrombocyte count, HbA1c levels, BMI, and pain levels. As we all know, there is a significant weight loss in this group of patients. So BMI is one of the criteria in this group of patients. But out of all this, the most commonly used, and we all know about it, is the Cambridge classification. Can we progress to the next slide, please? The Cambridge classification from 0 to 1, where 0 is normal and 4 is marked or severe. So 0 is basically visualization of the previous slide, please. 0 is basically visualization of the entire duct system with uniform filling of side branches without the asigner opacification, with a normal main duct and normal. That's a normal morphology. Number 1 is equivocal. The main duct is normal. 1 to 3 abnormal side branches. Number 2 is mild. Again, the main duct is normal. More than 3 abnormal side branches. Number 3 is moderate. Dilated main duct with irregularity and more than 3 abnormal side branches, and you will see small cysts which are less than 1 centimeter. And the class 4 is basically marked or severe. There are large cysts which are more than 1 centimeter, gross irregularity of the main pancreatic duct, intraductal calculus or calculi, that is in plural form, strictures and obstruction with severe dilatation. Unfortunately, most of the patients who are coming to us usually fall in the moderate to severe category, and that is really difficult for us to first go for the medical management, then plan for the endoscopic management, and if required for the surgical therapy. Coming to the next slide, please. Investigations. Now, everywhere we have, in whatever disease we are dealing with, you all know we have a routine set of investigations and certain specific tests. So first we go for the laboratory investigations, the routine ones: complete hemogram, liver function test, amylase lipase, electrolytes, including calcium, fasting blood sugar, postprandial sugar, and glycosylated hemoglobin. Specific tests, autoimmune profile can be done, IgG4 levels, ANA, ASMA, rheumatoid factor. Now, ASMA, I would actually suggest we can go for ASMA only if the ANA comes back as positive, because rarely we do get an ASMA positive in the absence of an ANA positive status. Lipid profile is very important. As we all know, hypertriglyceridemia is an important association. Genetic profile, in the genetic cause, it's an autosomal dominant disease. Chronic pancreatitis is the disease is identified in cationic trypsinogen gene, PRSS1, and mutation, the commonest mutation is R122H. For the hereditary chronic pancreatitis, there is replacement of arginine with histidine at amino acid position 122 of the trypsinogen protein. Don't have to remember so much in detail. Just remember PRSS1 gene. It's an important gene, and mutation in this is one of the commonest cause for hereditary chronic pancreatitis. Coming to the next slide, please. Now, non-invasive pancreatic function test. Whatever we used to have initially, for example, ERCP. ERCP is a very good, it's a very good test to detect chronic pancreatitis. But as we all know, it's an invasive test and it has its own risks, and it is quite difficult to counsel the patient and take the patient up for this test, and it may not be available everywhere. Now, the non-invasive pancreatic function test. You can see there are 4 tests which are mentioned over here. Pancreatic elastase test, that is the fecal elastase. Qualitative fecal fat test, chymotrypsin activity in feces. And what we see, the last one is 13C, mixed triglyceride red test. We are commonly using pancreatic elastase, that is fecal elastase. Fecal elastase is basically it's a marker for pancreatic enzyme secretion, and it will give you it has a sensitivity of like for mild endocrine for mild exocrine deficiency a sensitivity of 54%, for moderate 75%, for severe the sensitivity is 95%, the specificity is 85%. The drawback for this test is it is not available everywhere, and it's quite costly. I think currently one pancreatic elastase test may cost around 3,500 to 4,000 INR, which is pretty high. Patients don't agree to go for it. But pancreatic elastase test will actually guide you for the use of PERT in future. That is pancreatic enzyme replacement therapy. If you see that pancreatic elastase is low or literally undetectable, just start on the PERT regime. A qualitative fecal fat test is not very useful, and what we see is only severe exocrine deficiency has a sensitivity of 78%, but for mild and moderate, there is literally no response. Chymotrypsin activity in feces, again, the sensitivity is less than 50% in case of mild, and for moderates around 60%, and for severe it is 80 to 90%. Now 13C mixed triglyceride red test, something which we don't do on a regular basis. We don't do it at all, not regular basis. We don't do it at all. At least in our setup, we don't do it, and hence I cannot say much about it. But the marker is basically marker for impaired fat digestion. Common ones are the pancreatic elastase test and sometimes chymotrypsin activity in the feces. Progressing to the next slide, please. Imaging. Now, imaging, all of you know about it. Probably you might be knowing it better than me. Primarily CT. CT provides excellent. It's basically CT and MRCP. Wherever CT has a drawback, MRCP picks up, and wherever MRCP has a drawback, CT scores. So ideally, it is suggested that the patient, if possible, if financially feasible, we might take the patient up for both the tests. Now, CT provides an excellent information about morphological changes of the pancreas, such as the pancreatic duct dilatation or strictures, atrophy, calcification, and pseudocystic changes. The main drawbacks of CT are the limited visualization of the pancreatic ductal system and lack of sensitivity and specificity for milder forms of chronic pancreatitis. Although the sensitivity for the detection of calcification is better than that of MRI. Now, MRI will score where CT has a drawback, that is the limited visualization of the pancreatic duct system. I have given this picture over here. If you see this, it's basically a CCT image of a severe chronic pancreatitis showing ductal stones. If you can see in image A, there are white arrows, and in as well as in part B within the dilated pancreatic duct. So it's basically an orange yellow arrow which is pointing towards the dilated pancreatic duct, and the duct is pretty dilated in fact. Coming to the next slide, please. Now, MRCP has a high sensitivity for detecting strictures and dilatation in the side branches of the pancreatic duct. Images obtained by MRCP are essentially identical to those obtained by ERCP, which was once used for diagnosis. But as I have mentioned, the ERCP is an invasive method and it has its own risks, may not be available in all the setups. So MRCP is definitely scoring above ERCP in those areas. Dynamic MRCP, in which images are acquired every 30 or 60 seconds over a 10-minute period following IV secretin hormone injection, provides excellent spatial resolution and functional information on exocrine pancreatic insufficiency. If time permits, I would discuss about this dynamic MRCP after the presentation gets over. MRCP or dynamic MRCP can be considered as the first choice for classification and staging in chronic pancreatitis. The major limitation of MRCP is the identification of parenchymal calcification in small ductal calculi, where CT is specially sensitive. So, can we proceed to the next slide, please? EUS. EUS is definitely an upcoming modality, but EUS, as you know, is basically endoscopic ultrasound. You have a small US probe which is fitted at the tip of the endoscopy machine, and it basically it will give you an idea of the pancreas and the pathology, as well as the morphology from the lumen of the stomach, from the lumen of the first part as well as the second part of the duodenum, mainly the first and second part of the duodenum. Ideally, the second part of the duodenum gives a very good picture. But again, as you all know, ultrasound has observer variation. So similarly, EUS does have observer variation. So there are the relatively poor inter-observer agreement for EUS limits its diagnostic accuracy for chronic pancreatitis, but definitely EUS is one of the upcoming modality for any therapeutics which we need in both acute as well as chronic pancreatitis. Coming to the next slide, please. Management of chronic pancreatitis. So your patient is coming to you not to know about what diagnosis you're doing, not to know about the pathology or histopathology or the investigations that you're going to undertake for the patient. The patient needs management. The patient needs a control of pain. The patient needs to deal with the weight loss. The patient needs to deal with the maldigestion. The diabetes needs to be corrected. So what do we do in these cases? Can we progress to the next slide, please? Now, the aim of management is to alleviate symptoms, that is, reduce symptoms, most commonly pain, followed by exocrine and endocrine insufficiency, and to prevent further disease progression and disease-related complications such as bile duct obstruction, gastric outlet obstruction, portal vein thrombosis, and ultimately, definitely pancreatic adenosis. As we all know, chronic pancreatitis has high risk of progressing to adenosis. Pain is most often genuine, as I was mentioning, the primary cause. Genuine does not mean the others are not happening, but genuine means primary cause. But there are several secondary causes that should always be addressed, as they are easier to treat than the primary causes. Pathologies such as pancreatic duct stones and strictures are typically treated invasively, including endoscopic stenting, ESWL, and surgical resections and drainage procedures. Endoscopic management can be combined with ESWL in the presence of large obstructive stones. That is, you need to break down the stone before removing them, because larger stones are difficult to remove and rather it may cause more harm than good. There may be injury to the ductal system. That is when we are combining the endoscopic treatment, that is ERCP, along with ESWL. To the next slide, please. Now, different treatment modalities for pain in chronic pancreatitis. Primarily, it is the pain. So, risk factor modification, alcohol abstinence, stop tobacco usage, dietary therapy to improve the condition in general, including pain. It is very difficult to actually go for a proper dietary therapy because the patient in general is intolerant to all form of diet when they come in the moderate to the severe form of chronic pancreatitis. And alcohol abstinence, I would say that a proper counseling would be needed. And tobacco smoking, not just tobacco smoking cessation, it has to be, you have to ask the patient to stop using oral tobacco as well. That also is an important word. Now, initiatives to minimize the pressure in the duct system, pancreatic rest by tube feeding in the jejunum, that is the NJ tube, or nutritional products that do not activate the cholecystokinin. That is when we are using the elemental diet, uncoated pancreatic enzymes that may degrade cholecystokinin releasing factors, cholecystokinin inhibitors, proton pump inhibitors to increase the efficacy of enzyme treatment. Whenever you're using the uncoated pancreatic enzymes, you have to use it with the proton pump inhibitors. Analgesics, simple analgesics such as paracetamol and NSAIDs combined with proton pump inhibitors. I have rarely seen patients responding. If a patient is admitted in the hospital, you will rarely see the patient responding to use of paracetamol. Very rarely, very rarely. It may be one of the adjuvant medicines, but very rarely patients respond. Even the OPD patients, they rarely respond to paracetamol. NSAIDs are commonly used. Adjuvant analgesics, for example, gabapentinoids, weak or strong opioids, and plus laxatives. Invasive procedures like endoscopy, ESWL surgery, as I was mentioning before. And apart from that, there is a severe ganglion neurolysis, temporal neuronal block performed under CT, and splanchnicectomy, not very commonly done. In fact, in our setup, it's very rarely done. Spinal cord stimulation aimed at pain suppression, intrathecal opioids aimed at pain suppression. Intrathecal opioids, yes, I have seen patients getting them. Treatment of, but definitely not in from any setup in our city. Treatment of anxiety and depression, very important. TSADs are commonly given, SSRIs, cognitive behavioral therapy, including sleep therapy, anxiolytics. Neuromodulation aimed at improving pain, a host of neuromodulation given, like transcutaneous electrical nerve stimulation, transcranial magnetic stimulation, direct current stimulation, and physiotherapy. Experimental therapies aimed at improving pain and health status in general, ketamine, antipsychotics, clonidine, radiotherapy of the pancreas, nerve growth factor inhibitors, cannabinoids. I am not very much acquainted with the use of cannabinoids, but yes, I think there are places which are giving trials of this. But ketamine, I have seen one or two patients who have got ketamine. And antipsychotics, definitely antipsychotics, in fact, it is being used nowadays. Coming to the next slide, please. Now, exocrine substitution. The exocrine insufficiency is basically causing maldigestion. So the patient has a diarrhea, steatoria, weight loss, flatulence, abdominal distension, nutritional deficiency, and the main consequences of they are the main consequences of an exocrine pancreatic insufficiency. They can be avoided by appropriate pancreatic enzyme replacement therapy. Always remember appropriate. You cannot actually, when a patient needs PERT, PERT has to be given in full dosage. You cannot give a half-hearted dose of PERT. That is not going to help the patient in any way. Pancreatic enzyme, usually a combination of lipase, amylase, protease, should be administered orally with each meal or snack. So the topping up should be done with the snack. With each meal, you're giving a full dose, and with snack, you have to give half of the dose. Enteric-coated enzyme preparation in form of microspheres or mini microspheres improve digestion and absorption of nutrients. They relieve the symptoms and improve the nutritional status of the patient. Enzyme dose should be adjusted based on the volume, fat, and calorific content of the meals. I had mentioned previously that dietary counseling is very important. As a guide, starting dose of 40,000 to 50,000 units with main meal. Just see the figure, it's 40,000 to 50,000 units. And half of the dose with snacks is generally recommended. Enzyme dose should be further individualized based on symptom response and objective evaluation of nutritional status. Even if you're not giving 40,000, it should be at least 25 to 30,000 with the main meal. Okay, because data what we get is from other countries where they are supplementing 40 to 50,000. But in our country, at least it has to be more than 25,000. 10,000 units with each meal makes no difference on the part of the patient. If you're seeing prescriptions with 10,000 units with breakfast, 10,000 units with dinner, it will hardly cause any benefit to the patient because PERT is very important. Coming to the next slide. Management of diabetes mellitus. What, as I have said before, the diabetes that we are encountering in a case of chronic pancreatitis is basically type 3C diabetes. What happens in chronic pancreatitis, as I mentioned before, there is a progressive destruction of the pancreatic parenchyma. So obviously, there is destruction of cells of the islets of Langerhans. So you will not have insulin. So there is no point using secretagogues like sulfonylureas in this group of patients. They will glimepiride. You will see patients getting glimepiride. Then other secretagogues. None of them are going to help because there is a loss of the beta cells. So the ideal management for diabetes mellitus is insulin. You will have to counsel the patient and start the patient on insulin. Otherwise, you will see the patient comes back to you with a sugar of say 500, 600, and it is very difficult to control. They may come with DKA, right? And if the patient has mild hyperglycemia, you can try oral agents like metformin. But as you know, metformin itself has a lot of GI side effects. And in a patient of chronic pancreatitis who is already having a lot of GI symptoms, you wouldn't want to increase the symptoms by giving a metformin. Ideally, can we progress to the next slide, please? Okay. Then I will just go to the previous slide. I'll give them a detail about the use of insulin. So the insulin that we give is basically a basal insulin. What we prefer giving to the patient is basically a basal insulin. You can give glargine, you can give deglutec, but it has to be a basal insulin. And with each meal, you can give a rapid-acting insulin, that is a short-term insulin. We don't usually give pre-mixed insulin in this group of patients because with each meal, the requirement may vary. So a long-acting insulin at bedtime and a short-acting before each meal, the basal bolus regime. But you have to be very careful that the patient is taking proper meals because you are giving a shot of insulin and the patient is not taking meals, the patient may land up in hypoglycemia. So if you see the first point, it is very clearly mentioned, diabetes therapy in chronic pancreatitis should be individually tailored, not only to control the patient for hyperglycemia, but also to reduce the risk of hypoglycemia. Just remember one thing, a patient of chronic pancreatitis or for that matter of fact, any pancreatitis, even acute pancreatitis, recurrent acute pancreatitis, please don't use gliptins. If you're encountering prescriptions which are mentioning gliptins, please stop the gliptins because gliptins are known agents they increase the risk of pancreatitis in a patient. Coming to the next slide, please. Now, endoscopy, the intervention. So, in between the medical management and the surgical management is intervention. 30 to 60% of patients with chronic pancreatitis ultimately require some form of intervention, either endoscopic or surgical. The indication for endoscopic treatment is most often an intractable pain, and the treatment should be considered before the patient is becoming opiate dependent. We are very commonly using buprenorphine patch. We are very commonly using sentinel patch. Sometimes patients are using sentinel patches high as 75 mcg per hour. So these patients are ideal candidates for use of endoscopic or surgical intervention. The most common indication for endoscopic treatment are strictures of the pancreatic duct, obstruction of the CBD, and pancreatic cirrhosis. Several endoscopic procedures are available which differ in their potential benefits and prognosis. When there is an increased pressure in the PD owing to a dilated duct with stricture is assumed to be the cause of either pain or recurrent disease episode. Endoscopic sphincterectomy is performed first, in which the muscular valve, we have a small sphincterectomy, there's a knife, we give a small incision that controls the flow of bile and pancreatic juice and is usually followed by insertion of one or more plastic stents into the pancreatic duct. Whether the removal of intraductal stones or their disintegration by prior ESWL is of additional benefit is still being discussed and is not necessarily supported by high quality clinical evidence. So what we do is basically during the procedure, during the ERCP, we do a sphincterectomy and we straight away go and place a plastic stent. Plastic stent is something which needs to be replaced it needs to be replaced quite frequently. Probably in a period of 6 to 8 weeks, you might, or maybe at most 3 months, you may need to replace the plastic stent. Coming to the next slide. Okay. As per studies, they say that almost 2/3 of the patients get some benefit after use of endoscopic procedure. Now, in obstruction of the common bile duct, one or more plastic stents can be inserted into the bile duct after biliary sphincterectomy to restore the patency. Recently, fully covered self-expanding stents, that is FCSENS, have become popular. Membrane-covered metal or polymer. Like stents in PD, stents in the bile duct need to be regularly exchanged to prevent occlusion and cholangitis. In fact, it's not just cholangitis may arise due to long placement of stent. Even after placing the stent, maybe in the first 2 to 3 days, you might get episodes of cholangitis if the procedure is not carried out in a proper sterile manner. A suggested exchange interval of plastic stent is 3 months, whereas the fully covered stent may remain open for 6 months or longer. The FCSEMS seems to improve the outcome in a case series non-randomized and randomized trial with a stricture residue strain rate of up to 93% and the recurrence rate of strictures only. So they are saying that definitely a fully covered self-expanding stent is preferred. It can have a longevity of 6 months, but again, as I said, everything in our country comes with a cost. The cost of this is pretty high. So sometimes patients may prefer going for the normal stent that we apply this patient. But then we can counsel the patient saying that since the duration is longer, they can go for this stent, and the lesser the intervention, the better it is for the patient. Coming to the next slide, please. If you can see the stent, the first picture, part A, you see a transpapillary placement of stent, right? There is a transpapillary. If you see, it is across the papilla. The second one is intraductal placement. right? There is an intraductal placement of, it's a short length stent. And next we see there, in the next picture, we see insertion of the metal stent. As we have seen, as I said in the previous slide, there has been improvement of stricture after 6 months. So placement of stent is carried out, and they do give benefits, and there has been improvement of pain on the part of the patient. Coming to the next slide, please. Surgery, I am not the right person to talk about surgery over here because I think my audience are all surgeons. So the aim of surgical intervention is to alleviate severe, constant or recurrent abdominal pain and to cure or prevent additional organ complications, including biliary compression that results in jaundice, duodenal compression that causes gastric outlet obstruction, or vascular obstruction that potentially leads to portal hypertension or PVT with subsequent varicose collapse. So these are the indications. And what surgery is carried out, I suppose you know that better than me. I wouldn't go into details of the surgical management because I was asked to talk about mainly the medical management. Now, coming to the concluding slide. So the take-home message, chronic pancreatitis is defined as a continuing chronic inflammatory process of the pancreas characterized by irreversible morphologic changes in the pancreas. Abdominal pain is the presenting symptom. It causes definite exocrine and endocrine insufficiency, and that is where the management lies. Laboratory investigations, routine and special image and special tests, along with the non-invasive special tests that I mentioned, imaging like CT, MRCP, dynamic MRCP, EUS, pain management followed by management of exocrine and endocrine complications is the mainstay of medical management. Endoscopic management and surgical management to be undertaken dependent on the persistence of symptoms. And definitely we have to do that earlier to prevent, the earlier done the better, to prevent the progression of the disease and to prevent unwanted complications in future. Next slide, please. These are the references. You can have a look. There's a very good review article. You can read that. And coming to the next slide. Yeah, if you have any questions, you can ask me.
Shantanu, do we have any time left?
We have around 6.5 minutes there.
I can't hear anything.
The question is, what is microsphere and mini microsphere tablets? Hello?
Yeah.
What is microsphere and mini microsphere tablets?
Microsphere and mini microsphere tablets are basically formulations which are done for patients for enteric coated tablets, as you know, and they have a special module. They have a special, as you know, that they don't. They were designed to achieve variable site-specific release. So they are basically available in the capsule form, as we all know. And we have the enteric coated microsphere tablet and the uncoated tablets, as I had said before. So, but then the main disadvantage they they may cause, there may be certain loss of function of this particular formation. But the main thing is for the microsphere tablet is basically a targeted delivery of the drug, which is done, a site-specific delivery of the drug, which is done. It is basically a hard gelatin capsule body, and which a core tablet is placed. That's it. The size will differentiate it.
Okay. Thank you. We shall finish here.
Okay, I wanted to talk about the dynamic MRCP. There was no question about the dynamic MRCP because I haven't mentioned about it in the slide.
Okay, you can speak.
Because I was thinking that anybody knows about the diamond. You can, in fact, everybody can unmute. It's not a problem. It should be an interactive session. So anybody has any idea about what happens in dynamic MRCP? Anybody?
I think time is very short, so you please narrate it.
It's basically something where we give intravenous secretin. As you all know, secretin causes dilatation of the ducts, and that is when the ducts become very clearly visible on MRCP. Very interesting thing. So it is something which we read very often, but it is hardly done in our setups. But I suppose that it's something which we can start off at least in our setups, the setups where we are working. So I think it's done.